All right, everybody, welcome back. This is a video that I've been intending to make for a little while. I had the opportunity to present at the American Student Dental Association annual session early in March. And this is the slideshow that I used when I was there presenting. It's just taken a while for me to finally get it up and recorded. So thanks for your patience. It is something that Pacific Dental Services sponsored, so I need to broadcast that loud and clear. I am a multi-office owner dentist. My name again is David King. I'm partnered in several offices with Pacific Dental Services, which is a great group, by the way. For any of you who are interested in affiliating with Pacific Dental Services or working with us, it's a fantastic opportunity to work in a group that really has the patient and the people's best interest at heart. So let's talk a little bit about me. I grew up in Utah. I was born there, Idaho and Montana, lived in Kansas City for 25 years, studied jazz trumpet at Central Missouri State University, took a 2-year break, went to Taiwan as a missionary. When I came back, I majored in business for a little bit, then married the daughter of an orthodontist, and now I am a dentist. Been practicing about 20 years. I mean, not 20 years. Been married about 20 years. Been practicing about, 2006, 14, 15 years. So been through some interesting work positions. I did, work with my own group, started my own scratch practice, and then I merged with another little group. Then I was recruited to Albuquerque with Pacific Dental Services supported practice. Partnered there for a few years, really enjoyed that area. We moved back to Missouri to be closer to family. And right now I work in O'Fallon and in St. Peters, which are just outside to the west of St. Louis. So in a nutshell, here is every slide you're going to see. This is all of them. There are a couple of videos in here too that you'll see, but this is all of them. So let's talk about objectives. So my objectives with this lecture is to provide methods and processes to diagnose and educate patients on single-tooth dental implant therapy. I also want to assist in understanding the options available when restoring single-tooth dental implants and to articulate workflows for successful single-tooth dental implant restorations. Now this case that you're seeing here on the right side, this is a guided implant surgery that I had the opportunity to participate in. This is the final prosthetic. This is the process that I did, which was guided. You can see the tooth here. The implant osteotomy preparation here, then removal of the tooth roots, placement of the implant, scanning, bone grafting, then the final product here. So this is a great opportunity to throw in some digital dentistry. I did this case a few years ago in Albuquerque. Now, why is this information so important? Well, most dental students have limited access or limited to no practical implant restorative experience during school, limited access to implant patients. Generally, the implant cases that show up at most dental schools will be first directed to the residency programs, and then if there's any spillover, they'll go to the general dentists. Now, we all know that dental implants are the standard of care when we're talking about replacing missing teeth. Now, it's not the only option, but we know that dental implants, generally speaking, are the best option for almost everybody in almost every situation. Additionally, most general dentists don't begin placing dental implants until years after graduation, and many implant placing specialists are not focused completely on restoratively driven dental implant placement. Oftentimes, the implants are placed where the bone is, and not necessarily in an ideal location for restoration. So that's why this information is important. Let's talk about a case here. So this is a case of a patient who had 3 different implants placed by 3 different surgeons. You can see here their angulation is not ideal. There's the one on the left, here's the center, and the one on the right. And that doesn't speak for looking down on the occlusal plane, the difference in angulation there. Here's the bridge that the lab technician was able to manufacture. Beautifully done bridge. Thank goodness they were able to rescue us. But the angulation on these implants is not ideal, obviously. So had there been a little better restoratively driven placement, I think we'd been in a lot better shape. So this is a fun case, kind of as an aside. to speak about, let's see, how do I preface this? Not every patient, for not every patient will an implant work. That doesn't make any sense. An implant isn't necessarily the best outcome or the best choice for every patient. Not every patient has an implant as their best outcome, I guess, is what I'm trying to say. For some people, an implant just doesn't work well. So these are my two daughters. This is she's 15 now, this is my 17-year-old. You can see the little chopstick right here on the desk that my mother-in-law sent to them. And this is a YouTube tutorial. This is a lady with a ponytail, this is her hand. They're watching a tutorial about how to use a chopstick. So you can see, this is my 15-year-old, her chopstick in her hair looks great. This is Ruth Ann, my 17-year-old, her chopstick in her hair also looks great. But for some of us, a chopstick in the hair is not a good idea. That's obviously my head. Well, maybe not obviously, but that's my head. And yeah, the chopstick just didn't work really well for me, obviously. So we know that an implant isn't necessarily the best choice for everybody. But let's talk about diagnosing. Okay, indications for single tooth implant restoration. We're going to talk about this as our one of our main objectives is to help with diagnosis. Indications for single tooth dental implant restoration. Options for replacement of a single tooth edentulous space. We're going to talk about good, better, best, and we're going to talk about keeping it simple. So this is objective number 1. We want to provide methods and processes to diagnose and educate patients on single tooth dental implant therapy. All right, moving ahead, let's talk about what options we have. So option number 1, of course, dental implants. That's what we're talking about now. Dental implant's a great choice, best choice for almost everybody in almost every situation. That's my favorite thing to say, obviously. Here's a couple of implants. We're going to be talking about the differences between the two. A screw retained on the upper left, right here, and a cement retained on the lower left. So this is an Emax crown. This is an Emax abutment with a tie base. This is a hybrid abutment. And this is an Emax crown, lithium disilicate. And this is a titanium base that's attached to them. So this is a hybrid crown. Hybrid crown, hybrid abutment crown. All right, that's choice 1, dental implants. Second choice, bridges. Bridges are great options. So these are also lithium disilicate or Emax bridges. Great choices. Posterior bridge, anterior bridge. Sorry, they're a little bit trimmed out of there. The third choice to replace a missing tooth or missing teeth are, of course, removable prosthetics. So we have a full denture here and some different variations of partial dentures depending on what your favorite flavor is. So these are our 3 choices to replace missing teeth: implants, bridges, or partials. And then there's the 4th choice of doing nothing if you want to go that route. Let's talk about this case. So this is a patient who showed up to my office, and this is a case where an implant would have been a great option, but there were some mitigating factors, some reasons why we could not place an implant for this patient. Here's tooth number 21. Obviously borderline restorable, if that, probably not restorable in most situations. But we opted to, instead of taking that tooth out, because she couldn't, her health history would not allow us to take it out, we ended up attempting a restoration. So here is the endodontic procedure. And you can see the post-op endo. This is gutta percha. This is the Wave 1 system with standard master cone and sealer technique. And these are 6 titanium pins. And here is the final prosthetic cemented in place. So as I mentioned, we could not take this tooth out and place a dental implant, which would have been the best choice for her in that situation. However, it was not the best situation for her health, primarily because she was currently undergoing radiation and chemotherapy. The radiation therapy involved her jaw. And so we were not able to do any type of a surgery. The surgeon would not give us clearance currently because of the risk of osteonecrosis of the jaw. So in the end, what we did is we took that tooth, we restored it after endodontically treating it, and we put a crown on there. I think we're going on 2 years. She's not had any flare-ups. You know, the conversation I had with her was, I hope this works. If it doesn't, we might have to talk about the hyperbaric oxygen therapy, but for the time being, this is the best outcome that I'd recommend for you now. And she was really happy with that, to be able to save, or at least attempt to save, her tooth. Okay, let's talk about this case. This is that guided case that I showed you on slide number 1. Great case. Patient came in, tooth borderline restorable. We talked about good, better, best. Best option, take the tooth out. put in a dental implant. So we did use a guided process to take that tooth out and put in a dental implant. Now the type of implant that we used, or the type of restoration we used, was a screw-retained implant restoration. So this is lithium disilicate, or EMAX, connected to titanium, and this is screw-retained. So the titanium and the EMAX are bonded together outside of the mouth, and then it's screwed in to the implant. So that's a screw-retained restoration. Here's another view of that. So great option here in this single tooth missing in this area to go ahead and put in a single tooth implant with a screw-retained restoration. All right, here's a different situation on the left side, although this is that same case I was referring to just a moment ago on the right. So you can see the implant in place. These are where the root crypts are, and the implant in place. Looks like it's slightly perforated the sinus, but there was no sinus perforation based on the angulation. It's just radiographic that it looks that way. On the left side, here are two implants that were placed, and these are EMAX crowns, lithium disilicate, with hybrid abutments right there. So these technically are screw-retained crowns. I'm sorry, screw-retained abutments, but cement-retained crowns. So we would call this a cement-retained restoration because the abutment itself is screwed in, but the crown is cemented on top of that. So great case here as well. So minimums and maximums. One thing to take into consideration is we need a certain amount of space in between our implants and any adjacent surface. So here we have 2 millimeters that's necessary, and these are estimates. You can go and find the research and talk about and choose for yourself what research you would suggest. I think the bare minimum is 1.5. I shoot for 2 millimeters between an implant and a tooth. Between the implants, I always shoot for at least 2, but 3 is better, so we can have a healthy papilla as much as possible. And then 2 millimeters over here. Same thing here, mesial to distal, you want to shoot for 2 millimeters. You can do 1.5 millimeters. Same thing on the distal, 2 millimeters. And then buccal to lingual. I think the absolute minimum is 1 to 1.5, but again, I shoot for 2. For me, it's easiest just to remember 2 millimeters all the way around, except in between 2 implants we need 3. So that's kind of my rule of thumb when I'm diagnosing and looking at radiographs and talking with patients. So here's more of that case. Guided case, you can see this is using the, let's see, Simplant software, that's right. With the implant in place, you can see the different views and where the bone is, where the sinus is, and where we wanted to place the tooth in the implant. So all of you that are new to dentistry or coming out of dental school soon, this is going to be kind of the way of the future to do these surgical procedures under the guidance of 3D tomography and cone beam x-rays. So it's really exciting how dentistry is moving. I would suggest for those of you that are still in school is spend a good amount of time learning and studying this, because when you come out, you're going to need to make decisions based on what do I want to invest in, what kind of practice do I want to go into, do they have this technology, are they looking at getting into this technology? This is really the way of dentistry. Okay, so that's the diagnosing piece. Let's talk about education for our patients. One of the things that I'd suggest to you when you're talking with your patients about making a choice from the standpoint of what's the best outcome for them is try to keep it really, really simple. A lot of patients don't want all the details. They don't want all the gory details about bone grafting and about, screwing into the jawbone and torque on the jawbone and immediate placement, all this stuff. They just want to know what they need and why. Help them understand the consequences of what's going on and give them kind of a timeline as far as when they need to have it done by. Now, if you have a patient, for instance, that comes in and has a tooth that's been missing for years, and they are looking at getting a replacement, what's the urgency there? Well, there's probably not as much urgency as there would be if, you've got tooth number 7 or tooth number 10 orthodontically, the teeth have been ideally placed, and we need to get that implant in before before your teeth start shifting around and the implant becomes more of a difficulty down the road. One other final thought I give you on this slide is avoid the you need approach. Many of us, when we're when we're discussing with a patient what kind of treatment they need, given their situation, their indicators, their findings, a lot of us use the you need approach. We will say, well, you have a cavity on tooth number 3, so you need a filling or you need a crown. I would suggest avoiding ever using that phrase, the you need, those two words together, because it comes off, in my experience, to be a little too patriarchal, a little too paternalistic, a little too I know what I'm doing and you don't know what you need, I know what you need. And in my experience, it can turn patients away. So a better way that I would suggest when you're educating your patients as to what kind of treatment options they have is, I would explain it just like that. Well, here's the situation. You're missing a tooth here. We know that if it's left that way, over time we could see some shifting and gradually the bone will tend to dissolve and eventually making any type of a restoration down the road a little more challenging. So here are the options and choices. Choice number 1, I'd recommend a dental implant. A dental implant is a crown that's attached to an artificial tooth root, and you can see on the right side. And it looks and functions like a natural tooth and has the highest success rate. That's usually what I say to a patient. It tends to be the simplest, and it tends to prevent the most misunderstanding. When you start talking about titanium this and hybrid abutments and cemented, a lot of patients just don't have the clinical background or training that we have, and they kind of tune out, and then you end up answering the question 3 or 4 times and they leave frustrated. So keep it simple. Avoid overwhelming them with details. We know a lot of details, but that doesn't mean we need to share it with our patients. Now, if they ask for it, go for it. We have a lot of engineers, a lot of highly well-educated individuals in my practice in O'Fallon, and some of them want a whole lot of information, and I'm happy to share that information. But I don't normally offer it, as out of the gates. I don't normally just start throwing initial implant torque, ideal torque for immediate loading and all this stuff. I just don't go there because it confuses people. Okay, so after implant placement, some things we want to prepare for with the patient after we've educated them. Let's just assume they've moved forward. We want to make sure we get an implant surgeon restorative clearance. Now, whether that's you that placed the implant or a surgeon in your office or someone else, you need the clearance from whoever it was that placed the implant before we put something on it. So, parts and pieces, what to order and when. We have some surgeons we've worked with in the past. The moment they place that implant, they order the part and send it to your office. It's awesome. So you get the abutment or the impression coping. If you place the implants, I would suggest that you order them yourself, whether that's a titanium base for use with CEREC or some other scan post for use with a digital process we'll talk about in a little bit, or whether that's an impression coping. And I would suggest that you keep them together in a box or in a bin or somewhere in your lab with the patient's name and the implant placement date on them. Now, if the patient ends up moving out, you already have the part, you can, as a gesture of goodwill, thanks for being with us, here's the part you're going to need to restore it down the road, or you can send it off to the office they're going to. That way, when the patient comes back in and your office gets busy and the lead assistant overlooks the need to order and suddenly we want to take an implant impression and we don't have the coping and everybody's frustrated, that'll kind of stave that off. So we want to prevent that. We want to make sure we have the right parts and pieces. Make sure the patient is aware of the steps involved, and then talk with them about the financial puzzle pieces. All these pieces are really critical to educating our patients about how the process is going to work. Okay, so here's a case, an interesting case where the wrong parts and pieces were used. This is an implant crown on a model, obviously. This is Emax, it's screw retained. Let's look at a different angle. Yeah, there's obviously something wrong here. And then on the other angle there, flipped around. So yes, the problem with this particular case was I ordered the wrong parts and pieces, and I was relatively new to using the scan body process. So I put on a titanium base, but I told the computer software I was using a scan post. And there's obviously a height difference between those two, which ended up yielding a really tall crown. So needless to say, I was glad that I did not have this patient in the chair while I discovered this. Otherwise, it would have been really embarrassing. So I was able to do a little research, talk to some of my mentors with the CEREC, CEREC process that do this all the time, and they were able to help me. Yeah, you picked the wrong option. You're a failure. Try this. So anyway, all that being said, I would suggest that when you're educating the patient, or when you're finished with the Implant placement, whether it's you or the surgeon, you order the right parts and pieces, you document it in the chart, you keep them in a centralized area so that you know where they are. That way, when it comes time to get things moving on to the next step, you're already ready with the correct parts and pieces. Here's just an example of some parts and pieces that we can order. This, of course, is a torque wrench. These are Nobel internal conical connection, regular drivers, thumb drivers. This is for, I want to say that's for Straumann. This and this are for locator attachments, and that's for the multi-unit abutments. So you got to make sure you have all the right parts and pieces before you go down that road. Here are Nobel BioCare, Nobel Active internal conical connection impression posts. And here's some scan posts. This is a 6.5 wide platform. This is a regular platform. This is a narrow platform. And this is a 3.0 platform. You'll notice they come in different widths as well. I could get this yellow one in that width too. So again, you got a lot of things to prepare for. One of the nice things about it though is your sales reps with all the different companies you're going to be working with will be more than happy to give you a free seminar, probably feed you lunch at the same time, to explain what parts and pieces you need. They're always raring to do that. Second stage surgery. So if you are the one that's doing the second stage surgery after the surgeon has given you the thumbs up to restore, it's a really simple process. You want to find that dental implant. For me, if it's totally covered by tissue, usually you'll be able to see where the implant is, or generally know where it is. I would suggest providing a few drops of anesthetic right on the gum tissue. I wouldn't do a whole block or a big infiltration. You really literally need just a few drops, enough to blanch the tissue over the top of that implant. Blanch the tissue, and then I like to use an explorer or a sharp perio probe to determine exactly where that screw access hole is. And you want to center your tissue punch or your incision to facilitate getting that healing abutment or the healing screw off of that implant, assuming it's covered by the gums. Now, if there is the need to remove any bone, you want to remove the bone cautiously so that you don't damage the rim of the implant, because this rim, if it gets gouged or damaged, could compromise the long-term outcome. And then you place the healing abutment if that's something you're going to do. And again, this is one of those parts and pieces you want to order ahead of time. When you are using a tissue punch, they come in different diameters. You might get one that matches the size of your healing abutment. If you put a real narrow tissue punch in there, you won't be able to get your healing abutment all the way down. The same thing applies the other way. If you put in a really giant tissue punch and you have a really skinny healing abutment, you're going to have some gum tissue changes around there, which are not ideal. We want to keep that keratinized tissue rather than letting it convert back to a not so keratinized tissue form. Okay. Impression options. So now we're talking about restoring the implant. Let's talk about options for impression. You have two options. There's the digital and the analog option. And you want to make sure you get the right one. Same thing we talked about before, parts and pieces. You want things to fit. So let's talk about this real quick. This is a funny video that I shot while sitting in the McDonald's parking lot. That's obviously an Amazon delivery truck that didn't quite fit under that little order here bar. Well, what I thought is pretty funny is it looks like McDonald's had that issue before, and so they prepared. All right, so next step, we're going to assist in understanding the options available when restoring single tooth dental implants. So let's talk first about analog impression options. Two types, closed tray impression, open tray impression. These pieces that you see here are for closed tray impressions. That means we do not drill holes through the impression tray. We put the impression abutments in the implants. We take an impression, the impression comes out, then we unscrew these and they go to the lab together. So that's a closed tray impression. So here is an example of a closed tray impression versus an open tray impression. So closed, you'll notice the impression will completely go over the top of that impression body. With these, we need to open little windows through the top here before the impression tray will sit in there. And then when these are unscrewed, they'll come out in the impression body, which is pretty cool. So what does the lab need? Well, the lab needs the restoration arch, an impression of the restoration arch like you see here. They need the opposing arch, they need a bite impression. And then they need a shade. If you're going to do anterior stuff, what character indication, characterization. Do you want mamelon? Do you want shading on the incisal third, the middle third, gingival third? What form do you want? Boxy or ovoid or tapered? All sorts of options. You want to communicate more than you think you need. And when you're first starting to use a lab, you always want to make sure you give them more data than you think they want. If you're giving them less data, you're basically giving the lab techs, which might be well trained, you're giving them free range to go ahead and do what they want to do rather than what you want to do. Now eventually you might get totally on the same page with the lab techs and they know exactly what you want every time and it comes out perfectly, but I'd communicate more than you think you need to. Okay, moving on. So this is an impression analog, an implant analog rather, right here you see this piece. And that's the impression coping. This is Nobel Active Internal Conical Connection regular platform. This is screwed in. You can just finger tighten this little piece right into this implant analog. These will go to the lab. I would suggest when you get your cases back that you retrieve these out of the stone models for use in the future, because these add up. They get costly if you continue to throw them away. All right, let's talk about open tray impressions. Pretty exciting stuff. Place the fixture, verify the seat with an X-ray, just like you should do with a closed tray impression. You want to make sure you're cutting out the tray to facilitate access to these open tray impression copings. Then I like to use a light body impression over the copings and a heavy body impression in the tray itself. Remove the impressions with the copings inside. So once the impression material sets, then you'll unscrew these long screws or long pins, and when you pull the impression tray out, the copings will come out of the implants and remain in the impression. So it's a lot more accurate than the closed tray impression. So here are the differences here of the closed tray and the open tray, and you can see the open tray difference in the impression versus the closed tray. Some of these have the same. These are the impression copings actually screwed in here, and then these are the ones that were inserted after the fact. So closed tray here on the top left, open tray there. Open just means we're making a window so you can see in there. Closed tray impression process compared to the open tray. Same thing, you want to verify the fixture is seated all the way. Impression heavy and light body. Remove the impression after it's set. Then you remove these guys from the implants. These will eventually get popped back into the impressions and sent to the lab. I would suggest that you, as the clinician, make sure these go into the impression holes exactly the way you want them to be. You'll notice the indexing. They can be forced in, but they're not quite in right, and then you'll end up doing a whole bunch of adjusting. And you want to make sure you have the right screws and parts and pieces for this case, or this process. So here's a closed tray impression. You can see, like I mentioned before, you can get different sizes of impression copings. These are the same size dental implant themselves, but the impression copings were different sizes. This is obviously a wider one, that's a narrow one. The three pieces we needed to send to the lab, plus the lab script and the characterization indications. Here's a little break from Implant Restorations. These are some CEREC same-day smile makeovers. Really like the lower center and the upper center ones, but these are all cases that I had an opportunity to do in the same one-day appointment with these patients. Oh, I think I just lied to you. This lower left, this is 2 appointments. We did the top and then we did the bottom, separate appointments. But this one is the largest number of crowns I've done. There's actually a separate video on my channel. This is 24 crowns done in one sitting with CEREC. But these are all same-day CEREC processes. Amazing what we can do with digital processes if we're willing to kind of step out on a limb and learn a little bit and put ourselves through some challenges as far as learning new processes. Let's talk about the digital scanning process. So if we're going to do it digitally rather than impressions, we're going to remove the healing abutment, place the scanning fixture. We're going to confirm that the scanning fixture is interlocked appropriately with an X-ray usually. Complete the scanning of all the relevant tissue, upper, lower bite, and then replace the healing abutment. So this is a tie base that you see at the top, a titanium base with a stainless steel screw, and this is a scan cap. This titanium base has a counterpart called a scan post. These are the ELOS scan bodies for the Nobel process, and they come in for different implants as well. They're all based on the size of the implant platform. You can see 3.0, 3.5, 4.3, and 5.0, the regular platform, and then the wide platform. So here's a video that kind of walks you through what that process is using the scan body. So you can see me there unscrewing the healing abutment. There's the healing abutment. You can see the tissue form nicely. This is the titanium base, which I'm going to use as a scanning body. We'll screw that in, and then we'll slide on a scan cap, which is a little white cap. Incidentally, this patient here is one of my dental assistants, fantastic dental assistant, fun guy to work with in Albuquerque. He really was a lot of fun. I really enjoyed working with John. You can see me negotiating getting that scan cap. Those have to go down in the right orientation. Otherwise, you're going to end up with a dental implant that's rotated because the computer that you're scanning into thinks it's rotated. And this is the scanning process. You can see that's a CEREC OmniCam scanning automatically, and I'm just going to create a little 3D modeling of that lower arch first, and then we'll do the upper arch here in a second, and then we'll do a buccal scan. Pretty exciting stuff. Now sometimes when you have a scan body in there or a scan cap, the patient will not be able to close down all the way because of the height of the scan body or scan cap. So be careful, you don't want to traumatize or damage the scan body or scan cap. And then I'm just going to switch out the scan body, the scan cap, and put back on the healing abutment while we manufacture the implant crown. Oh, yep, sorry, I left one piece off. We are going to scan so we can see where the gingiva is relative to the scan post, the scan body. All right, here's the design process. This is obviously not the same tooth. I couldn't track down that. I don't think I screen recorded that case. But this is the process using the CEREC 4, I don't remember, 4 point something version software. The design process, pretty straightforward stuff. One of the things that I've learned over the years is when we're designing these implant restorations, we want to make sure that we are dictating the gingival contours. Sometimes we have a tendency to allow the gingival contour to be dictated, or allow the crown shape or the abutment shape to be dictated by the gingival contour. Well, I think we're in much better shape if we can manage the gingival contour so that it provides or facilitates a good long-term restoration outcome. Otherwise, we'll end up with plaque traps and potentially higher failure rates for our dental implant restorations. Excuse me, and for our dental implants as a whole. So just manage that as you're designing. You want to make sure that you are actually creating the emergence profile that you want. Pretty fun stuff, right? Okay, on to the next step, the restoration types. So we're going to talk about two types, cement retained and screw retained. And here's, you can see the difference. Cement retained here just means we have an abutment and the crown itself is cemented on the top. And then screw retained, it screws in, obviously, duh. Now if you wanted to look at the abutment itself and ignore the crown, the abutment is screw retained. However, the crown itself is cement retained. So our next objective is to talk about workflows for successful single-tooth dental implant restorations. So, cement retained. Some of the benefits: there's no access hole, no need to patch after we fill it. Conventional cementation process. There is a slightly higher, marginally higher risk of peri-implantitis if we don't manage it well. Here's a couple of options of cement retained, or a couple of pictures of cement retained. You can see if they're designed well, you should have a really tight interface of the crown to the abutment. And you can see these should match perfectly when it goes into place. So cement retained, generally in my experience, we tend to gravitate to in the anterior just because of the access hole of the implant. We don't want, a hole where the screw comes out of, coming out the incisal edge. That's less than ideal cosmetically. So oftentimes, in order to correct that or deal with that, we put in an abutment and then we cement the crown onto the top of that. Screw retained. No cement, easier to manage the risk of cement necrosis because that cement, the crown itself, is connected to the abutment outside of the mouth. So this margin can be managed extraorally. I can polish this and make sure it's totally cement free. They're a little easier to retrieve and there is better retention. There's no risk or much less worry about the crown itself coming out or coming off. Okay. Here's a couple of images of screw retained, and you'll notice that these are posterior. This is the same posterior tooth. Oftentimes the posterior crowns lend themselves to be a little bit more often screw retained because we have an access through the occlusal surface. All right, we have 6 more slides. We're almost there, people. Delivery process. Removal of the healing abutment, trying of the restoration in the abutment. We want to verify the tooth and tissue pressure. Adjust to seat, complete seat. We want to make sure it's seated all the way. But the first thing we have to make sure is seated is not the crown or the restoration, but the abutment, the metal part that interfaces with the implant, has to be seated correctly. So the orientation is critical. Once we've verified that is seated with an x-ray, then we torque it to specification. And then we want to protect that abutment screw, whether it's with Teflon tape, or with dental floss. I would suggest avoiding using anything that's biodegradable like cotton rolls or cotton plugs. Some docs will use like PVS, light body PVS impression material, and others will use some sort of a resin. But I would suggest you make it easily retrievable just in case you have to cut through and get that screw out of there. You don't want it to be covered by something like cement. Okay, let's talk a little bit about the age-old question. To bond, cement, or to lute? That is the question. What do we use to cement these crowns on to a cement-retained restoration? I was trained in dental school that used temporary cement because the tolerances between the abutment and the crown are really, really high. They mesh together really, really well, so there's less need of that bonding process. Personally, I prefer to just use conventional cement, eluting cement, not temporary cement. I like to use Fuji-Sem. It's easy to clean up. Auto setting. Any cement, to be honest, is fine. I would just recommend against using a temporary cement as a permanent cement for an implant crown. Now, if you're using it temporarily, that's perfectly fine. But I would suggest avoiding using a temporary cement as a permanent implant cement because it'll end up being more temporary than you want it to be. Manage the occlusion. Unless we're doing multi-implant restorations that are connected and abutted to one another, we want to make sure the only contact should be in maximum intercuspal position. There should be no protrusive or excursive or retrusive or intrusive or any other intrusive type of interferences, because that'll tend to lend itself to a higher risk of failure of the restoration or the screw or the implant. So manage that contact. And I like to, once the patient has left, I like to have them back in a couple of weeks to confirm that the occlusion is still good, do any adjusting that's necessary, evaluate the tissue response, and then follow up routinely with a PA in a couple of months, 6 months. Yeah. So I think we've done a pretty good job talking about methods and processes to diagnose and educate patients on single-tooth dental implant restorations. Did we assist in understanding the options available in restoring dental implants, single-tooth implants? Yeah. So we talked about screw retained and cement retained. Workflows, yeah, pretty straightforward. We talked about those as well. So I think generally this has been a success. That's the lecture. I've got one more slide just for fun. This is kind of a mishmash, a hodgepodge is that a word? Of a bunch of cases, including the Big 24 implant restoration or crown restoration case that I showed you before, with some of the GoPro recordings that I've tried as well. Working on getting a little better magnifier for the GoPro. Those two images are a little bit grainy, didn't quite turn out the way I wanted them to. I definitely want a point of view there on the right side. But yeah, thanks for tuning in. Hopefully this has been an entertaining or at least informative lecture. I know it's kind of long. I prepared an hour-long lecture for the ASDA students. Hopefully this hasn't been too boring. But please let me know what questions you have. I'm happy to answer any questions, and if you have any requests for additional videos, I'd be happy to see what I can do for you. Thanks.